Let's look at why, in these stuff, there's hardware. Why bother to even describe it? I mean, well, I think that if you know what something is, obviously you're going to do a better job interpreting a study. More importantly, I think it increases your credibility with the subspecialty physicians. I'm really serious about this because, I mean, think about it. Which statement sounds like you know what you're actually talking about? And this is irrelevant as whether you really do or not, okay, but we all know it's how you sound. So there's metallic density, object, possibly a prosthetic valve superimposed on the heart. Now, I've seen reports that are literally this bad. If you want to be a little better, you could say the aortic valve has been replaced. And then, okay, you recognize the aortic valve, and there's some information there. But if you're, with just a little bit extra effort, you could say it's been replaced with a bovine pericardial prosthesis. And then regardless of the rest of your report, somebody's going to get the impression that you actually know what you're talking about, and that's half the battle, right? But if you use the first thing, then nothing else in your report is going to sound like you know what you're talking about. It'd be like the radiologist who dictated there ain't no nodules in their lungs. Might be technically correct, but where's your credibility? So I would encourage you to be as specific as you can, if for no other reason than to increase your credibility. So I'll talk about these four things briefly, and just go into some stuff you guys probably already know. But just to refresh, because there's a lot of new stuff in the EP world, and I'm fortunate enough, I guess, to have a group of very aggressive electrophysiologists that live around the corner from me, so I'm constantly having to reevaluate how I look at these. So the classic pacer positions in the right atrial appendage or against the right atrial free wall. And then the RV outflow tract or the apex, depending on where it captures better. And these locations are beloved by electrophysiologists because they're stable. But they don't pace physiologically. They don't use the normal conduction system of the heart. And as you may remember from way, 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 way back, for some of us, way, 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 way back, that when you pace the RV, you get a left bundle branch pattern. Well, that's not physiologic, and it's okay if you have a normal heart, but if your heart is already messed up by coronary disease, this can be an issue. So here's just an example of a classic position in the right atrial appendage and then the RV apex, nice stable positions for pacemaker leads. This one's in the right atrium against the lateral wall, and this one's in the RV outflow tract, and it's there, I presume, because that's where it captured the best. At least that's my assumption most of the time. Now, there's a new trend to use physiologic pacing, which employs as much of the native conduction system as possible, and this is, primarily the bundle of His. And so pacer positions may be different now. They may pace the sinoatrial node in the bundle of His. These are more difficult to place, and the positions are less stable. So your average electrophysiologist is probably going to stay away from this, kind of like we stay away from describing things in the heart. But here's what some of those look like. And the reason I show them to you, this is an SA node pacer here, this is a bundle of His pacer here, is that you don't look at this and say the pacemaker leads are malplaced or malpositioned. So anytime I have a question, unless it's obviously in the wrong place, if I have a question about a pacemaker placement, I call the electrophysiologist. Our cardiologists actually speak to us. We're on friendly terms. And they say, yeah, I'm trying to pace the such and such. And then I put that in my data bank, and the next time I can sound very erudite about that. This was an interesting pacemaker. You might think, well, this thing slurped into the coronary sinus, and it shouldn't be there, but they were actually pacing the left atrium through the coronary sinus. So again, right atrial lead looks like normal position. This lead, you say, geez, that's not where it should be. Maybe it flipped from the RV into the coronary sinus and back. Call first, and this was intentionally placed in the coronary sinus to pace the left atrium. So one of the earlier things in trying to be more physiologic was biventricular pacing. It's called ventricular resynchronization therapy. And there's a lot of really excellent evidence that when the ventricles in a bad heart, say one with coronary disease or cardiomyopathy, are paced using the usual from the apex of the RV, then you can get a lot of what they call negative remodeling, which is a fancy cardiology term meaning that the ventricle gets even worse than it was to start with. And so the RV gets paced typically from the outflow tract of the apex as usual, but you can't get to the LV from there. So you could put something across the septum and the mitral valve would be a bad idea. Probably putting it across the aortic valve would be even worse. So what they do is they pace from a left-sided cardiac vein. And so I'm sure all of you by now have seen catheters that are going way around to the backside of the heart and maybe out even lateral like this pacing the left ventricle. And this is a case where the RV was pacing the apex, and for whatever reason, there was probably an old epicardial lead pacing the LV. And this may have been from the time before they were very adept at getting catheters or pacemaker wires out into those veins. Now, pacemakers, as you know, get into problems and dislodge leads and leads in the wrong location, cardiac perforation, and this used to be very common with the old temporary leads, probably not so much anymore, and of course, wire fractures. If you remember almost nothing else from this talk, if you remember that when atrial leads are not pointed upward or horizontal, they're almost certainly not functioning. So this was an atrial lead, it flipped down. There's no way this is going to capture. This atrial lead, I don't know whether, I assume it didn't get put in the azygos vein on purpose, but it somehow managed to migrate its way up there. I'm not aware of any native conduction system that would warrant pacing the azygos vein, so you might be pretty sure about saying that one's abnormal. And then, of course, every once in a while, the blue thing they're supposed to be into is a little redder than they think, or they don't notice it's redder than it should be, and you'll end up with a pacemaker in the ventricle. And this happens with temporary leads, in my experience, more than with permanent leads, but it can happen with any of them. And then lead perforation. Now, of course, if you're like me, I look at CT scans and I see all this metallic artifact, and I'm never quite sure whether that really thin RV wall is perforated or not, but when you see a pericardial effusion, it's at least worth mentioning. And I'll usually use some obfuscation, like the RV lead appears to project beyond the RV free wall, but just kind of appears so that they don't get upset. But with a pericardial effusion, that was confirmed to be a lead. Now, this isn't actually as bad as it looks because it usually tamponades the hole, and the patients don't suffer too much. But if it goes too far, of course, it can pace the diaphragm. Now, everybody recognizes, when leads are grossly disrupted, and if we just think to look at it, we see them. Of course, a lot of times we don't. These more subtle fractures are harder to pick up, and in fact, you shouldn't pick this up because this is a suture where this is sewn into the patient's skin. So don't mistake this very subtle black lucency, I guess that's redundant, this little subtle lucency through the wire for being a fracture. That's normal. Defibrillators are a different story. Everybody pretty much calls these AICDs, but in fact, if you're into semantic correctness, an AICD is a surgically implanted device which has patches on the surface of the heart and then usually has an epicardial pacemaker associated with it. What we see now is the intracardiac, so drop the A, it's an intracardiac defibrillator which is put in through the subclavian vein. Again, does it make any difference whether you call it an AICD or an ICD? No, probably not, but you do sound better if you use the correct term. And this is an AICD with these big patches that are sewn onto the heart and then epicardial leads pacing the ventricles. This is an ICD. The older models grounded to the PAC and to a ground lead that was usually somewhere in the SVC or adjacent structures. This patient also has a dual chamber pacemaker with an atrial lead. The ventricular lead consists of the pacing sense end and then the buzzing end. And so these would ground from here to here and here. The newer versions are devoid of this lead, at least the ones we use at my institution. So again, just the distinction. The ICD is an intracardiac device placed through the subclavian vein, and the AICD is placed during cardiac surgery. And there were several versions of this, and this was an old kind of a round patch AICD that failed, and so they replaced it with a typical ICD here. Again, in this case with a right atrial pacer, but this is not necessary. I've seen a couple of cases where they've actually decided to put defibrillator leads in a posterior vein, much as a pacer lead, as well as in the right ventricle. I'm not sure why that happened, but it did in this case. So moving on to valve positions. Valve positions can be kind of confusing on frontal films, at least to our residents who seem to chronically get them incorrectly. In the frontal position, the tricuspid valve is the most to the right and the lowest. The mitral and aortic valves sit side by side with their annuli touching each other. The aortic valve is more medial and above the mitral valve, and then the pulmonary valve sits up above all of it and is the farthest to the left as a rule. A little easier on the lateral view when the if you believe in dividing the heart half in two from top to bottom and from thirds from back to front, then the typical aortic valve, whether it's native or prosthetic, will live in that upper middle third. The mitral valve typically in the posterior lower third. The tricuspid valve will be quite far anterior, and the pulmonary valve will be quite high. Now, I have to say that I think I've only seen one, maybe two pulmonary valve prostheses placed in the native position. Most of them are in a conduit, and I'll show you an example of that in a little bit. From the frontal projection, it can be hard to distinguish a mitral valve from an aortic valve. Notice these will both have a similar orientation, and if you don't have two valves side by side, it can be very difficult. But if you go to the lateral view, you notice the mitral valve has a vertical orientation, and the aortic valve has a horizontal orientation. And so if you have a lateral view, you can tell for sure. Other people prefer to draw a line from the hilus to the anterior cardiophrenic angle, and typically the aortic valve is above that and the mitral valve is below it. May be important when it comes to identifying calcium, but if you've actually got a lateral view with mechanical or bioprosthetic valves, you can tell without worrying about where that line is just based on their orientation. The scanogram showing a patient who has bioprosthetic mitral and aortic valves, again demonstrating, in this case you can tell which way the blood flows, so it's no problem telling this is a mitral and this is an aortic. But if these were just rings, you might have more difficulty. But in this case, you can see which way the prongs point is the direction of flow in these bioprosthetic valves. Now, you can also see these on CT quite nicely. They tend to have a lot of artifact, even the valves that don't have metallic components. So this is a St. Jude aortic valve. This is a St. Jude mitral valve. This valve, particular version of this valve, is made out of pyrolytic carbon and has no metal pieces in it, which makes it almost invisible on a chest radiograph, unless you're lucky, but quite visible on a chest CT. So again, the position is you glean the position from where it sits. This one's sitting over the aorta, obviously, and this one's back in AV groove. Now, if you run into this valve, a tricuspid valve, it's going to be unusual to see this as an isolated valve replacement. And so your first thought is going to be this is a mitral valve. But if you look at it, you'll notice that it's too far to the right, and it's really too far anterior, unless this left atrium were huge, and you can see just from the chest radiograph that the left atrium is not huge. So don't fall into the trap of looking at this and knee-jerk saying it's a mitral valve replacement, because this one, in fact, is not. And this is one version of a St. Jude valve, which has a metallic base ring, unlike the CT I showed you a minute ago. And this is that same patient with the tricuspid valve, St. Jude in this case, in the tricuspid position. This was done, I believe, for infective endocarditis. So just true through prosthetic cardiac valves. Mechanical valves come in basically two forms, some type of disc, tilting disc being most common, and in the olden days, the ball and cage. Bioprosthetic valves are animal tissue, and it's important, they're on a synthetic frame. Some folks have the misconception that this is an animal valve that is removed from a probably unwilling animal and placed directly into a human, and that's not the case. These are animal tissue that's originally laboriously hand-sewn onto a prosthetic stent by little old ladies in France for Alain Carpentier. Nowadays, I'm sure it's a little more, I'm lacking on the word I need, but a lot more sophisticated than that. And then there's cadaveric homografts. So you can, in some cases, you'll actually use a cadaver valve to replace a native valve. And then there's the autograft. And you guys were probably not aware that a certain small minority of the population has a spare valve tucked away in the thoracic cage that you can take out and use wherever you want, right? Or not. The Ross procedure is where they take the pulmonary valve and move it to the aortic position, and then they do an RV to PA conduit, which, I'll show you a little bit later. So these are the four types: mechanical prostheses, bioprostheses, homografts, and autografts. So just to look at the mechanical prostheses, the classic was the Starr-Edwards, the single tilting disc valves. There have been a number of them. Most prominently, where I practiced, have been the Bjork-Shiley valve and the Medtronic Hall valve. And then there's several double tilting disc valves out. The two I'm familiar with are St. Jude and a newer valve called an On-X valve. And I just show you this for historical purposes. The chances of you finding a Starr-Edwards valve in one of your living patients is getting remote, because they haven't been installed in at least 30 years. In case you do come up with the question, there was only one model that was MR incompatible. The rest of them were fine. This was a Bjork-Schiley, which was kind of the original tilting disc valve. There were some others where the disc moved up and down, and this was a very popular valve. Notice there's no hinge, it was just contained between the struts. It had a very characteristic look, and this was a very popular valve until the latest model had problems with strut fracture, which left the disc to play flying saucer out into the systemic circulation, resulting in acute severe regurgitation, which usually didn't fare so well for the patient. The Medtronic Hall valve is very similar, has a little bit different look. Again, I don't know that it's important you know that this is a Bjork and this is a Medtronic valve, but I think it's important to know they're mechanical tilting disc valves. The St. Jude valve is a double tilting disc, which actually has hinges or axles, if you will, and it comes in two models. The standard model is all pyrolytic carbon. That was a valve I showed you on the CT scan, and it is virtually invisible unless you happen to catch the leaflets directly in profile, either one or both of them. So when you have a sternotomy and you don't see signs of a CABG, or even if you do, look carefully to make sure you don't see too little parallel or maybe one very dense line telling you that there's a St. Jude prosthesis. The newer ones have a very thin base ring, or some of the models do, which is easy to recognize. Unfortunately, this looks like some of the older bioprosthetic valves, but currently I'm not familiar with a bioprosthetic valve that looks like this, so that's also a mechanical valve. And again, this is what it looks like. In this case, it happened to be partially open and partially closed here. Now, the Onyx valve is another double tilting disc valve, and this is used primarily in children to the best of my knowledge, and it looks like this. It's kind of strange looking. So if you see these two little flying saucers sitting in the middle of the heart, you can look really sharp and say, an Onyx valve in the aortic position. Now, the bioprosthetic valves come pig flavored and cow flavored, and mixed integrated flavored, if you will, bovine and porcine tissue. This was one of the original bovine valves, the porcine valve. So again, this was the one that the little old ladies in France hand sewed the pig leaflets onto these metal stents. From the outside, it looks a lot like this valve, which is the currently most commonly used valve where I am, and it's made of a bovine pericardium, which again is sewn onto this framework. It has a narrower struts and it has this visible base ring. Many think that this is a valve you need, and I'm very fond of this valve because I have one installed in myself. And it's quite easy to recognize on CT scan because you have these three little struts. If you see them on end, they all have a fair bit of artifact associated with them. And you can actually, on thin section CT, you can actually see the struts like that. So that's the bovine pericardial valve. St. Jude has now also come out with a tissue valve, which is, I believe, a combination of pig and cow. And true to their form of not liking to make it easy for us to recognize their valves are even present, this valve is almost indiscernible. In the original X-ray, you can see a little, very faint wire right there. I'm not sure whether that even projects up there. So again, St. Jude is not our friend in terms of visibility of their valves. Now, why distinguish mechanical from bioprosthetic? Because this patient rolls into the ER unconscious or intoxicated or whatever, and you look at the chest radiograph and you see a valve, the clinician may not know the valve exists, and they need to know whether this patient is likely to be on rat poison as a blood thinner. So I think it's critical that you at least identify the valve as bioprosthetic or mechanical prosthesis because of that single fact. Annuloplasty rings should not be called valves because you'll sound ignorant if you do that, and they're used to correct valvular regurgitation, and there's really no true aortic or pulmonary annulus technically. These are only used in the mitral and tricuspid positions. And you can recognize them because they're either not round, and I mean, a valve may be kind of off kilter and look like it's oval, but you get the impression it's round if you really look at it, or they're not complete. And here's what I mean by not complete, and this is a tricuspid annuloplasty ring in a patient with a bioprosthetic mitral valve, had rheumatic heart disease. This is another tricuspid annuloplasty ring. So in this case, this ring is not complete. Other rings are not round, okay? And they can cause a lot of artifact on your chest CT. Sometimes it's hard to distinguish an annuloplasty ring from mitral annular calcium until you look at the scanogram or a chest radiograph. And this is another one. This one looks like a ski mask, if you will, from the front, ski goggles, and from the side it looks a little different. This is a geoform ring. Again, you know, you look at this and say, it's a mitral annuloplasty ring. If you can, say it's a geoform mitral ring, then everybody will think you're very bright. Now, there's another way that valves get put in, and that's as part of a graft. And when a patient has annular aortic ectasia or Marfanoid type aorta, and sometimes post-dissection, they will get what's called a composite graft, where the valve is actually part of a Dacron graft, and this requires reimplantation of the coronary arteries into the side of the graft. So this is a different operation. It takes longer and it has more complications. Here's what one looks like. This was a St. Jude valve. I'm sure you recognize with the two discs here. And this is the graft material is high density. Now, the problem with these, particularly the old way they were done, is that they tended to leak. And you may have noticed that these labels have migrated. I assume as the clot got bigger, the labels migrated. So this should be out here, and this should be over here. This is clot, false aneurysm. You can actually see one coronary looks okay, and then the other coronary ostium was disrupted right here. So this was a complication that is fortunately less common since they stopped wrapping the ascending aorta around wrapping the native aorta around the graft. They quit doing that, and it cut down on the leak rate. Now, there's another kind of conduit used, which is the RV to PA conduit, which is used to repair lesions. We have a combination of severe pulmonary obstruction and a VSD, basically tetralogy of Fallot and all of his cousins and first cousins and second cousins, transposition, double outlet, and all that. And these are usually done with a Dacron graft containing a prosthetic valve. They will also use an aortic or a pulmonary homograft, in which case you're not going to be able to recognize it because there's nothing there to see. The thing to keep in mind about these, and we'll explain the radiograph if you're confused, is that the pulmonary valve position will always be more craniad than the native valve position. So here's just an example of an old conduit. This valve isn't even made anymore. This was a pericardial valve. But notice the pulmonary valve should be down here somewhere, and this one's way up here. And pulmonary valve should be right in there, and this one's way up here. So this, when you see this, you know that this is in a conduit, then you know automatically that the patient either had truncus arteriosus or tetralogy or something like that. And here's an example of a post-op TET with all kinds of paraphernalia, coils and collaterals, a stent in the pulmonary artery, and this valve right here. This was an old Hancock porcine valve, which is not where the native pulmonary valve should live. So when you see this, you know what the diagnosis was. A number of devices have been developed over the years to close holes in the heart percutaneously. I'm sure there's about a jillion more than I've ever seen. I'll show you some of those. Also, surgically, pericardium and synthetic patches used to close septal defects. Those are only visible when calcified, and then of course coils are most frequently done to close ductuses and to close systemic to pulmonary collaterals in patients with cyanotic heart disease. So here's one type of atrial septal closure defect. Looks a lot like an On-X valve, except it's not where a valve should live, and it's really big. So one side that crosses the septum, then it expands, and then they kind of screw it together and close the hole. This is another kind. So that's the Flying Saucer brand, and this is the Spider brand. And when you see this, your job is really just to determine where it is, because as you know, the history may not be complete. In this case, a couple of spiders were placed down here, and this is obviously not in the atrium, which is back here. Everybody forgets about cardiac anatomy, but in fact, you've all looked at jillions and jillions of CT scans, and I bet on every single one of them that the atrial septum is in posterior to the ventricular septum, right? So anyway, so this is a ventricular closure devices. And sometimes you'll see strange-looking calcifications in the heart that don't correspond to the valve, they don't correspond to the coronary or anything else. And if you look carefully, you'd notice that this patient has very tiny wire sutures in the sternum, telling you that their surgery was done as an infant or a young child, and then you can draw a logical conclusion that this sits right below the aortic valve in the region of the membranous septum, and that in fact is a ventricular septal defect patch. Coils, again, are used to close things, as there are in interventional radiology of all types. And then every once in a while, you run up against something that you've never seen before. And you look at that picture, which admittedly is a pretty crappy picture, I'm sorry, and you ask yourself, or maybe you might add another word where the dots are, I'm not sure, it depends on whether you're couth or not. And you say, geez, I don't have what that is. And this one is a Jarvik 7 heart.